Hello, everyone, and welcome. This is Chelsea Cronin lecturing today on restrictive versus obstructive lung disease as part of this week's respiratory content for NU 325. Before we begin, I'd first like to address the flipped classroom model, as I know this is new to many of you. More specifically, how to ask questions if any should arise while you're viewing the online lectures. The quickest way to receive a response if you have a question is to email me. My email is cmcronin@lcsc.edu. Email allows me to answer you most urgently, but you're also welcome to bring any questions that you have to class, and we can discuss them in a little bit more detail during class time. If it's something that you anticipate may take a little bit extra time for discussion, please do email me ahead of time. That allows me to plan some extra time to discuss and clarify things better during our class time. So please don't be shy about asking and emailing with questions. If you have a question, likely so do many of your peers, so it really is helpful to everybody. So please don't be shy about asking questions. So let's go ahead and begin with the lecture. Most of our time today we're going to be discussing obstructive airway diseases, and there's really very little that I actually want you to know about restrictive lung disease. Basically that it limits the full expansion of the lungs. In restrictive lung disease, lung volumes diminish as a result of decreased lung or thoracic compliance. Examples of restrictive lung disease would be cystic fibrosis, pulmonary edema, sarcoidosis, and some neuromuscular diseases as well. But that's about all I expect you to know about restrictive lung disease. So we'll go ahead and begin our discussion of obstructive lung disease, which occurs when airway obstruction limits the airflow on exhalation. This causes a prolonged exhalation time, and the lungs have difficulty moving air outward. Examples of obstructive airway disease would include COPD, emphysema, bronchitis, and asthma. This image depicts three types of obstructive airway disease. COPD is subclassified as either chronic bronchitis or emphysema, which are illustrated in the blue circles there. Asthma is its own entity, and asthma is unique because it's reversible where COPD is not. So we'll begin by discussing asthma, which is a chronic inflammatory airway disease where a stimulus causes the airways to narrow. That narrowing is what we call bronchoconstriction. Asthma is characterized by recurrent episodes of audible wheezing, breathlessness, chest tightness, and coughing. It's more common in children, and reversibility is the key to diagnosis, meaning that the incidence is episodic and recovery is obtained through intervention. So on the left, we have a normal bronchiole there, and on the right, an asthmatic bronchiole. And so you'll see that bronchoconstriction is illustrated there, and also the mucus production in the middle of the bronchiole there. So here's another image depicting the bronchial tube leading up to and during an asthma attack. So you can see the difference. Left, again, normal. Right, during an asthma attack. So let's talk about triggers. In allergic asthma, an episode may occur if an individual is exposed to a trigger. Potential triggers are exposure to allergens, exercise, cold, inhaled irritants, GERD, emotional stress, and respiratory virus. And this image depicts several common allergens. So I have respiratory viruses listed first, and this is important because I want you to remember it. This will be on your exam, so recognize that respiratory viruses and upper respiratory infections are very common precipitating factors to asthmatic episodes. Outdoor activities can also trigger an episode. This is due to increased exposure to cold temperatures and environmental allergens. Activity tolerance also plays a role. Somebody who has a higher activity tolerance may be less affected than somebody who is not as active. Asthma and gastric reflux, also known as GERD. GERD is another potential trigger. The stomach acid triggers hyperresponsiveness when it enters the esophagus, and that can trigger a nerve reflex causing shortness of breath. Excess stress can also provoke an asthmatic. And common signs and symptoms would include shortness of breath, dyspnea, chest tightness, not being able to fully inhale air, increased respirations, increased heart rate, bronchoconstriction, wheezing, coughing, and even anxiety. Initially, we talked about ABGs last week. Initially, the ABG would represent respiratory alkalosis and with a decreased oxygen saturation. But as the attack progresses in severity, the ABG will shift to a respiratory acidosis. And down there, highlighted in the yellow, lack of wheezing may mean worsening of the attack, and we consider this an ominous sign. So if you don't hear anything, that's definitely not good. Let's talk about reactive airway disease versus asthma. So patients with reactive airway symptoms may develop some of the same signs and symptoms as asthma after exposure to irritants, including the reversible bronchospasm. The question is, how long do the symptoms persist? And if the symptoms persist greater than 6 months, then you would consider it asthma. Reactive airway disease is a more short-term thing. Asthma has an increased occurrence in males. The onset is usually in childhood, and it does show familial inheritance. An asthma attack can be a true emergency. If symptoms persist and do not respond to normal treatment within 30 minutes, patients should seek emergency medical attention. Status asthmaticus can be life-threatening, so we really do need to treat this urgently. So it becomes a priority. So how do we diagnose asthma? Well, one of the tools we have is pulmonary function tests. So asthma is diagnosed with pulmonary function tests, most importantly, the peak expiratory flow rate. So I'll say that again, peak expiratory flow rate, and we also use ABGs. Patients may also require skin testing for allergens, and PFTs we're going to use at baseline and then post bronchodilator administration. Okay, so classification of asthma severity. So with intermittent asthma, patients will experience occasional flare-ups. Medications that we're going to use are albuterol, or levalbuterol is the other name, which is a SABA, or a short-acting beta-2 agonist. It is a bronchodilator and works by relaxing smooth muscles. You're going to talk in great detail about these medications in pharmacology, so I'm not going to go into detail for your med-surg class. All patients with asthma must have a short-acting beta-2 agonist on board, so that's something you want to remember. Inhaled corticosteroids are initiated if patients need to use their SABA inhaler more than twice weekly. Corticosteroids, however, are not effective for an acute attack. And if they're using the inhaled steroids, it's important to educate the patient to gargle or rinse their mouth out after using the medication. And this is done to reduce the risk of developing an oral candida infection. You might know this as thrush. Okay, so a step up would be moderate persistent asthma, and that requires a step up in therapy as well to a low to medium dose of a long-acting beta-2 agonist, like Foradil or salmeterol. Again, you're going to discuss these in pharm, so I'm just very briefly discussing them now. In addition, we're going to use long-term controller meds like fluticasone, which is a corticosteroid, and combination therapies like Advair, Dulera. Mast cell stabilizers may also be used, as well as leukotriene modifiers. But again, you're going to learn all this in pharm. So severe persistent asthma may require a high-dose inhaled corticosteroid and a long-acting beta-2 agonist. If that doesn't cut it, they may need oral corticosteroids in addition. So they may be on inhaled corticosteroids and also oral corticosteroids. So when we're giving somebody steroids, we want to be assessing them closely because you probably already know that steroids can mask the signs and symptoms of inflammation and infection, and they also have lots of other side effects. So we need to be assessing our patients closely and watching for any signs or symptoms of infection. Potential side effects include the risk for infection, increased blood glucose, restlessness, agitation, and stomach upset. These are the additional side effects that we want to be looking for with steroids. Oral steroid dose, you want to remember, may also require a taper dose to get them down to a lower dose before they can eventually stop. Steroid inhalers are what we call the gold standard. Inhaled steroids are the most effective long-term control drugs for persistent asthma. We want to always remind them to gargle and rinse their mouth following each use to prevent the candida infection. So preventative measures with asthma would include allergy testing, which is done via the skin. And this is, again, a preventative measure in hopes of avoiding any potential allergen triggers for that particular patient. So this is unique to your patient. Daily exercise is recommended to improve conditioning. And so it's important to teach your patients on the correct use of inhalers, when to measure their peak flow, how to measure it, and we really want all asthmatics to have an asthma action plan. So we're going to discuss these in detail in class. Peak flow meters measure the airflow through the bronchi and the degree of obstruction. And there's a few pictures there. I'm going to bring some of these to class so you can put hands on and kind of see how to use these. And you want to teach your patient about the zones, so it's just like a stoplight. Green is good, yellow requires caution, and red is poor. Emergency care of an asthmatic may include the use of short-acting beta-2 agonists, that's considered the rescue inhalers, IV corticosteroids, possibly epinephrine, oxygen administration, and IV fluids. Okay, that's a good spot to pause, and I will see you again for the next portion of our respiratory lecture.